People don't understand that this is the only disease that robs you of who you are, and every single memory that you have, every memory that you are building in your 20s and 30s and 40s can be taken away from you just like that because of the choices that you choose to make. Today's guest is Dr. Kellyann Niotis, the first fellowship-trained preventative neurologist. Currently, we have around 50 million people worldwide that have this disease. That number is going to triple by the year 2050. In my opinion, it's going to be the collapse of our healthcare system.
We're about to hit a really big epidemic of neurodegenerative diseases.
In this episode, we uncover how Alzheimer's and other neurodegenerative diseases can be detected early and even prevented. What would you determine high risk?
Everyone with the brain is at risk. If you die with Alzheimer's disease pathology in your brain, but you lived a perfectly happy, cognitively normal life, did you have Alzheimer's disease? No.
Expect a deep dive into genetics, hormones, biomarkers, diet, and the future of brain health.
Having biomarker positivity does not mean that you'll get Alzheimer's disease. You have to have symptoms.
And why prevention may be the most powerful tool that we have. If you were to tell the world, here are my top 10 things to prevent Alzheimer's disease, what are they?
I love this. Okay, put me on the spot.
I'm Louise Nicola, and this is the Neuro Experience. You're a neurologist, board certified, but you are focusing on preventive neurology. What does that mean?
Yeah. Well, first of all, thank you so much for having me today. I am beyond excited to sit here and talk to you about this. I know we share this drive to get education out there and really, really make a dent in the onset and prevention of various neurodegenerative diseases, not just Alzheimer's, which I hope we'll get to talk about. But the whole field of preventive neurology is brand new, and it's analogous to the idea of preventive cardiology, which is identifying people at risk who do not have obvious clinical symptoms and applying early interventions to reduce the risk of developing various neurological conditions. In my particular niche, it's neurodegenerative diseases. So that includes things like Alzheimer's, Parkinson's, and Lewy Body Dementia.
So why don't we do just a broad overview of all of this? Because we always hear the word dementia, and I think people still have a hard time differentiating between dementia and Alzheimer's disease and all of the other dementias. So why don't we just do a very quick overview of everything?
You know, we like to say dementia is this umbrella term. It encompasses neurodegenerative forms of disease, but also other forms of dementia, which can be from depression, for example, which is pseudo-dementia. In our world, we'll focus on sort of neurodegenerative diseases. We can kind of break that down into Alzheimer's, which is really the most common form of dementia. Then we have vascular dementia, Lewy body dementia, and then a lot more atypical forms of dementia like frontotemporal dementia, Parkinson's disease dementia, and it keeps going more and more rare from there.
Do you believe that dementia is just for older people?
Absolutely not. We know that the pathological changes of these diseases occur years before the first obvious symptom. And in the research that I'm doing through the Institute for Neurodegenerative Diseases, we really are testing various biomarkers of neurodegenerative diseases in at-risk patients, not just those who are impacted. And we've found pathological changes in people's 30s, which is shocking to think about, but it's real and it's present. And I view these people as prime candidates for prevention because I truly, truly believe that a large majority of these cases are preventable if we just know how to find them and know what interventions to apply at the right time.
We're going to focus a lot in this episode on Alzheimer's disease because you said that's the most common out of all of the dementias. You know, what exactly is Alzheimer's disease from a pathological view?
There's a lot of debate now about how we define Alzheimer's disease. And this has really come to the forefront of a lot of experts in the field because now, like I alluded to, we have blood-based biomarkers where we can identify disease pathology in people who don't have symptoms. So how do we define Alzheimer's disease and how do we diagnose it? It's a clinical pathological diagnosis. So you have to not only have pathological changes present, such as amyloid proteins, tau proteins, present in the brain, identified whether in the spinal fluid or the blood, but you also have to have the clinical symptoms for the disease, because if you die with Alzheimer's disease pathology in your brain, but you lived a perfectly happy, cognitively normal life, did you have Alzheimer's disease? No. And we theoretically can say that we prevented it in that case. The pathological changes don't define the disease. It's the clinical symptoms.
So it's both based on symptoms, and you do this through imaging. You do symptoms, but also
imaging or biomarkers.
Yeah. It's interesting because it used to be called the amyloid cascade hypothesis. Right. This is when we used to demonize amyloid. We're not still demonizing amyloid right now.
It really shouldn't be demonized. And I get a lot of messages and emails from a lot of people who, rightfully feel that because of bad science and bad players in the field, that all the research that shows this association between Alzheimer's disease and amyloid is just fake and not real. And at the end of the day, we do recognize that amyloid is a pathological feature of Alzheimer's disease. Whether or not it's causative of Alzheimer's disease is a different discussion. I do believe these toxic proteins are involved and do trigger their own bits of neurodegeneration. But whether they're the exact cause, it's very debated. I personally think there's a lot of upstream changes that happen that trigger these changes. But regardless, amyloid and tau proteins are involved in Alzheimer's disease. But only a third of people that have Alzheimer's disease follow that classic amyloid cascade where it goes amyloid, tau, neurodegeneration. Only a third.
We can both do a bit of a neuroanatomy lesson here because I do think it's a network insufficiency. And especially when we're talking about amyloid, because that lives outside of the neurons in the CSF, different to tau. But we've got around 100 billion, and feel free to interject, 100 billion neurons approximately. And they all have around 10 to 15,000 connections. And the way that they connect with each other is through these things, I call them legs, these little dendrites. And when this is how we communicate, how we think, and this is how neurotransmitters are going from one neuron to the next. But what ends up happening with amyloid is when the amyloid builds up, it messes with the communication between neuron to neuron. And that's where we start seeing those symptoms occur. We start seeing, whether it's in the hippocampus, where I believe it's the first part to go during these diseases, depending on which one it is, you start to get memory loss. But then it's other symptoms too, right?
You hit that. I mean, there's so many other effects that amyloid triggers, like we mentioned, activation of our neuroimmune cells or our glia cells, which causes a whole cascade of inflammation, which doesn't do well for memory and thinking and personality and so forth.
So let's start from the start, because I'll tell you where I sit right now with the disease. I sit at the aspect of it's driven through inflammation. I know that it's just such an easy thing to say. It's so easy because inflammation, innate immune system triggers amyloid. Amyloid's there as a protective molecule, if you will, and then it doesn't get cleared out and we just keep going through that cycle. It's like my broad overview. Is that wrong in saying that?
I mean, there's no right or wrong because we don't truly know the answer. I personally believe with all neurodegenerative diseases that there's really unlikely one pathway that explains the disease in everyone. I think different people may follow different pathways to disease, which is why I'm in the business of personalized and precision medicine. I think in some people, their brains have cholesterol homeostasis issues, which ultimately will trigger an inflammatory process. But other people might have metabolic derangements in their brain or energy utilization issues in their brain that are triggering that inflammatory process. So I like to say that everyone's on their own unique path to this disease and there may be multiple paths involved, and we have to think about this disease as really a multifactorial disease that involves different drugs, different treatments, lifestyle interventions that target different pathways of it.
It's interesting because it's not a disease of genetics alone.
No, absolutely
Which
not.
is still where we're getting a bit wrong when it comes to the general population, understanding the disease. oh, I'm not going to get Alzheimer's. I don't have the disease. I don't have the genes. So,
yes.
And people still don't understand genetic mutations, risk genes. So let's start from that, because I want to approach this from a person who has no idea, and maybe they come to you and they're like, listen, my grandmother died of Alzheimer's. By the way, who knows if she did or not? Because, I mean, that's another thing. Who knows what's actually on the death certificate? Was it frontotemporal? Was it Parkinson's? Was it dementia? Like, we don't know. More often than not,
it's not Alzheimer's.
It's not Alzheimer's. It's just dementia.
Yes.
It's like dementia with delirium. It's like, okay, what does that mean?
Right.
And that upsets me, because it was the same with my grandmother. I'm trying to figure out, was it, where did it start? It was cancer. And it just says on the death certificate, pancreatic cancer. But when we were there, I clearly remember it was a different diagnosis. So that's a whole new ball game. But let's start with, somebody comes to you and they're just scared of getting Alzheimer's. What do you do to start with?
I do love starting with the family history, because I think it provides so many rich clues about the person who's sitting right in front of you. That's, the best way to get a look into what that person's risk could be. I like to ask really detailed questions about their family history. I don't ever accept that the diagnosis was dementia. I ask specifically about what symptoms they had, what age it started, what other medical conditions they had, how their life was. Were they a stressed out person? Did they live a pretty healthy lifestyle? Did they have a fall? Like, how did the process and disease start? And again, what symptoms did they have? That really, really helps not only understand who in their family is at risk, how many family members are at risk, how high risk is the person sitting in front of you, but also what likely other processes might contribute to the person who's sitting in front of you's risk.
If it's not a disease that's purely driven by genes, how important is the family history?
I still think that it's very important. I think that it's not purely driven by genes, that's true, but it is polygenic.
Yeah.
And I think that the family history, whether or not they have one of the known high-risk genes or a collection of smaller at-risk genes that put them at risk, it still provides us a lot of information. We know that people with a first-degree family member, whether or not they have a known gene, are at a higher risk of disease. So family history is really important.
Yeah, and what's sad now, especially in the public system, is a patient history is taken within 5 minutes.
Oh, I know.
So we do family history and we find out, maybe they don't know too much about how maybe their grandmother or their mother or father were affected, only if it was very prominent and they were the primary caretakers of that individual. But you go through family history, and then what else would you start doing? Would you start doing genetic screening?
I don't think genetics are for everyone. I am a huge proponent of certain genetic testing, specifically ApoE testing, but I also really acknowledge and have a careful discussion with the person sitting in front of me about the risks and benefits of it, because there are emotional risks associated with it. There are long-term risks in terms of eligibility for disability insurance and life insurance. So there are serious considerations, but it, in some cases, so changes the recommendations and what I think about a person's risk and how I would change the medications they're on, the supplements they're on, based on what I see in their genes.
The ApoE4 gene is really, it's a gene that I think people are so scared of. And there's genetic counseling for those who are testing positive. I've met so many ApoE4 carriers, obviously. I've rarely met an E4. I am envious for the E2, E3s. I'm a 3-3.
I'm a 3-3 too.
Oh, really? Yeah, so it's a null. It doesn't mean we've raised our risk or it's increased our risk. Why don't we just go through exactly what the ApoE4 gene is?
Yeah, and I also want to note, because it is a little bit unclear about how protective ApoE2 is.
Don't. Absolutely.
So, we, in general, on large population-based studies, it does seem like people with the ApoE2 gene are at a lower risk of Alzheimer's disease, they can and still do get it, but when they get it, it tends to be at a later age. People have better cognitive performance later in life, but there's a growing body of literature that actually shows they're at risk for some other diseases. One, frontotemporal dementia, and two is actually cerebral amyloid angiopathy, which is related to Alzheimer's disease. Instead of the Alzheimer's plaques being built up in the actual brain tissue themselves, they're building up in the blood vessels of the brain and leading to blood vessel friability, small bleeding in the brain, big hemorrhagic strokes if people have high blood pressure. So it's not all great to have ApoE2. It can still increase your risk for certain diseases. So that's just to be thorough there.
Yeah.
But yeah, let's talk about ApoE4. Do you want to?
Give me a full masterclass on it.
Okay. So, I mean, I have a love for lipids. Tom,
yes,
I'm going to give out a shout out to Tom Dayspring. He's an amazing mentor of mine. And, I feel fortunate enough to be able to pick his brain and have learned really alongside him so much. So ApoE4 or ApoE is a lipoprotein. It's involved in lipid transport throughout the body. It's made in the liver, but centrally it's also made in the brain, specifically made in the astrocytes of the brain. And in the brain, it's involved in a lot of different processes. It is one of the primary lipid transport proteins in the brain. It helps shuttle lipids and fatty acids between astrocytes and neurons. Neurons actually aren't the main producers of cholesterol in the brain. It's the astrocytes, and the neurons are very dependent on these supporting cells to deliver cholesterol that they need for synthesizing neurotransmitters, maintaining the health of their dendrites or their little fingers, like you said, their cell membranes, communication between cells, and so forth. So people with ApoE4 have less efficient lipid transport between these two types of brain cells, and lipids can get stuck in places that we don't want them to, like inside the astrocytes. And when Dr. Alzheimer's back in the day described Alzheimer's disease, he described these lipid droplets on pathology inside the brain cells of patients, inside the astrocytes of patients. And could it have been, and we'll never know, but could it have been he was really seeing this in our E4 patients who really had those lipids causing cytotoxicity or causing injury or death to the brain cells because they were getting trapped in there. So that's one pathway.
Why were they getting trapped in there?
Because ApoE4 can't transport the lipids. Okay. They have deficient lipid clearance and deficient lipid transport out of the cells.
Okay.
That's one pathway. ApoE4 may contribute to neurodegenerative diseases. We know that ApoE4 carriers have a lot or a robust neuroinflammatory response. It evolved as a protective gene. People who had ApoE4 were at lower risk for certain infections, diarrhea, illnesses, things that we don't die of nowadays. So it's not necessarily an evolutionary advantage today, but back in the day it was. And these people mount very robust immune responses to infections, which may be another key contributor to how these people may be more predisposed to the harmful effects of certain viruses. And we're seeing that more and more as some science unfolds.
If you care about the health of your cells and the health of your muscles, then you need to know about this compound. It's called urolithin A, and it's one of the most promising compounds in longevity science today. One of the things I focus on every single day is cellular energy, because longevity starts in your cells. And that's why I've been taking MitoPure gummies from Timeline. They're the first ever clinically proven urolithin A gummies. What that means is they actually recharge your mitochondria, which are the powerhouses in your cell, so you can feel stronger, recover faster, and age better. I've noticed a lift in my energy and less dragging during workouts and long work days. I have to tell you, I also take the urolithin A capsules, and it's not just another pill, it's life-changing. If you want to stay strong and energized as you age, and you want to know more about this, then head to timeline.com/neuro for 20% off. That's timeline.com/neuro. Your cells will thank you. All right, guys, let's talk about hormones because no one talks about hormones enough, yet they control everything. Our energy, our mood, our fertility, our metabolism, how our brain ages, our sleep, the list goes on. I know when mine feel out of balance because everything feels off and I'm quite cranky. That's why I started using Glow by Beam. It's a once daily hormone balancing blend with 18 active ingredients, pure electrolytes that support metabolism, immune health, collagen production, and more. I literally add just 1 scoop into water and it becomes the easiest, most delicious part of my routine. I've noticed better skin. And it doesn't taste bad. It actually tastes good. My favorite flavor is the blue raspberry. Over 40,000 women trust Glow, and now it's your turn. So visit shopbeam.com/TNE and use code TNE for up to 35% off. Shopbeam.com/TNE. Everyone has 2 genes. Two alleles, one from mum, one from dad. So can you just describe what it means if you're an E4, E4, E2, E4?
Yeah, let's go really basic. So everyone has 2 copies of the ApoE4 gene, or ApoE gene. As you said, you can have a 2, a 3, a 4, and you get 1 copy from your mom, 1 copy from your dad. And us scientists and doctors call that a genotype. Mm-hmm. So the most common genotype, as you said, is ApoE33. More than half the population has that. It doesn't increase our risk for Alzheimer's or Lewy Body Dementia directly, but of course understand that people with this genotype still can and do get these diseases. I think they probably just follow a different pathway than people with the higher risk genes. And then you can have a combination of any of these 2, 3, 4 together. So you can have an ApoE 2-3, an ApoE 2-4, an ApoE 3-4, and an ApoE 4-4. I'm always really hesitant to give exact numbers by which ApoE4 increases someone's risk.
Because right now, currently, from what I'm hearing, is the general consensus is if you've got 1 copy, it raises your risk 3 times.
If you look at these big population-based studies, it's somewhere between 2- and 4-fold.
Okay, so 3 times is probably approximately right. And then 4-4?
Somewhere between 8- and 12-fold. And what does that mean?
Exactly.
What does that actually mean?
Did you read that study, which I was actually traumatized when I actually spoke about it openly on a podcast? It was the study where they saw, I think it was it in Africa? I won't say exactly where it was, but it was a large population of individuals there have the E4. Oh,
yeah. I know the study you're talking about. The the one that said that essentially E4 was deterministic, a genetically deterministic form of Alzheimer's disease.
Because what they found was that just because they were E4 carriers, raising their risk of getting the disease 10 to 12-fold, but they had a very low population actually getting Alzheimer's disease, even with the E4.
This goes back to what we were speaking about in the very, very beginning. Alzheimer's disease is a clinical pathological diagnosis, and the harm of using just biomarker positivity to diagnose Alzheimer's disease is real. That caused so much undue stress and worry. I see a lot of people who have the ApoE44 genotype, and some of them have completely normal biomarkers in their 60s and 70s. It's a biased population, a biased pool that study really came from. And again, having biomarker positivity does not mean that you'll get Alzheimer's disease. You have to have symptoms.
It sounds the same as perimenopause, just because your hormones are phenomenal and on track. But if you've got the symptoms, then that's a different story. It seems like the same thing.
Similar.
Now, there's also other genes involved in this disease. We've got the amyloid precursor protein, presenilin 1, presenilin 2, which we can talk about. But there's also another 70 genes as well.
Yeah.
That we never hear about or speak about.
TREM1 is one of them. CLU.
Oh, CLU, yeah. Interesting.
There's so many. And again, aside from these very deterministic genes like APP that you mentioned. These diseases are polygenic. There are so many genes that increase or decrease our risk, and there are probably synergistic effects between the genes that, just because you have ApoE4, you might have inherited, for example, a Klotho gene that protected your ApoE4.
I want that. You've said the word biomarker quite a few times, and I know that you have a strong interest in biomarkers. Why don't we talk about what that is and what you're discovering right now?
This is an area that's exploded. It's become possible to get these tests yourself.
Yeah.
The issue is that these biomarkers haven't been robustly studied in at-risk populations.
Specifically for Alzheimer's disease.
Specifically for Alzheimer's disease. So what we know about some of these FDA-approved biomarkers, for example, the new one that came out, or the new one that was recently FDA cleared, was the Lumipulse G p-tau 217 over amyloid beta 42 ratio. That, again, is for a specific age range of people over 55 with cognitive symptoms. And the same is true for other commercially available biomarkers like Precivity AD2 test, which again tests amyloid beta 42/40 and p-tau 217. These are for people over the age of 55 with cognitive symptoms, because we know, and what we're really interested in studying at IND is what are the normative values or ranges of these biomarkers in different groups of people, different ages, different biological sexes, because they are different, and in people who don't have clinical symptoms. What's normal in that group of people? It hasn't been formally established. So that's an area that needs a lot more research. And unless you are working with a clinician who really understands these biomarkers, I don't recommend people getting them tested on their own, because it has, and I've seen it firsthand, led to so much undue stress and anxiety. Not to mention that, the way that these biomarkers are handled and processed really impacts the results. For example, amyloid proteins are so sensitive. If they're left out at room temperature, the amyloid will get stuck to the sides of the test tubes and you'll get false results. So
how did that even get FDA cleared?
It just has to be handled really properly and put on dry ice or negative 80 and sent really appropriately. But, if you're mass doing a lot of these things, you can imagine, especially in the summer, how things can kind of not, the quality can suffer.
So you're saying that people at high risk, what would you determine high risk?
If you have a high-risk gene and a significant family history, meaning more than one family member with the disease, you're at high risk. But everyone's at risk for these diseases.
Yeah.
We're at risk despite having ApoE33, ApoE33. Everyone with the brain is at risk.
Especially those who live in Manhattan.
Absolutely. People who live in Manhattan are at risk. Pollution, stress, all the things.
So these biomarkers actually can be exactly the same, I read, as getting a PET scan.
In someone who is cognitively impaired.
Yeah.
They have a high correlation to CSF or PET positivity of biomarkers in people who are cognitively impaired.
There's so much discussion around why 2/3 of Alzheimer's disease patients are female. And there's two branches, as I see. One is because of menopause and estrogen. Then there's the other one, well, women just live longer.
Yeah.
And 2/3 of caregivers are female as well. So females are really taking a hit right now with this disease. Can we just talk first of all about the gender differences?
Another area that I'm really, really fascinated by, I think biological sex impacts these diseases in ways that we have yet to really learn. On the other hand, we know men are at 1.5 times higher risk of Parkinson's disease, and why. And when we say, the hormone thing, which is, well, we know estrogen is protective for the brain, so women are at a lower risk for Parkinson's because they have estrogen. But then we also say women are higher risk of Alzheimer's disease because, estrogen fall off.
And estrogen is protective against Parkinson's.
It is, yes. We do understand that estrogen is neuroprotective.
Yes.
The idea behind, this hormonal shift and this opportune window when women seem to be more predisposed is really that perimenopausal period where there's rapid fluctuations in female sex hormones that put women disproportionately more at risk. We know that there are estrogen receptors in the brain, and the brain will upregulate these estrogen receptors during that time to really try to soak up as much estrogen from the blood as possible. But, there's so many other changes that happen during that midlife period for women that happen alongside menopause. Body composition changes in their lipid panels, changes in their metabolic health, all downstream impacts are all things that can contribute to Alzheimer's disease risk later in life. Poor sleep, increasing anxiety, mood changes, all things that really impact risk.
So would you say that having bioidentical hormones would be protective against this disease?
I, in general, am a proponent of using hormone replacement therapy. Of course, the right answer is that we need really robust studies, right? Of course, that's the right answer.
Yes, of course.
And I would love that. I would love if we had really robust studies using bioidentical hormones, but we don't. So what do we do now to help our patients? I think using hormones and the right person at the right time is beneficial, not only short-term for their cognition, not only do they start to sleep better, not only do they start to feel
like a human again.
Yeah, more cognitively sharp. But in our own research in women who we've started on hormone replacement therapy, we're actually seeing really promising biomarker changes in those women who we put on hormones. So I think used at the right dose in the right woman at the right time, there's a potential there.
Yeah. I read a really great study and I actually tracked it because I'm going to do a single episode on it. It was on testosterone, something that we don't speak about because it's all about females, estrogen, but we have more testosterone than estrogen, especially in our 20s and 30s. And I'm telling you, people are going to turn around in 20 years and we're going to have robust studies that proves that testosterone has a correlation, low testosterone to dementia and Alzheimer's disease, and people are going to be like, Louisa was right.
Progesterone too. We don't talk about progesterone.
No, we just talk about estrogen.
We just talk about estrogen, but progesterone is the mood hormone. Give some women progesterone and it's anti-anxiety, calming, soothing. Of course it's involved in how our brain works. Of course it is, but we just don't know as much about it. And that's why I said the right answer is we need more studies.
Yeah. How do you feel about testosterone?
I don't personally use testosterone in my clinical practice, although I've seen a lot of women come to me on testosterone who have reported major cognitive benefits on it, also benefits in terms of their body composition and their libido. The studies that we do have are all in men, and we see short-term cognitive improvements in men. We see correlations in men between higher levels of testosterone and lower risk of Alzheimer's disease, but whether or not that's causative, we don't really know.
You've said the word body composition, and it reminds me of the risk factors for dementia or Alzheimer's disease. I've got to really start, differentiating between the two. What do you think about those? Do you think they should be updated?
I'm just grateful that we put together this list finally and that more people are recognizing that 45% of dementia may be preventable. I absolutely think that that's an underestimate. I truly, truly believe that a large majority of dementia cases are preventable. I wouldn't be doing this if I didn't. So I'm, just grateful that that message is getting out there from a really credible medical journal and people are believing it, because when we first started down this pathway...
smoking and obesity, go figure.
Yeah, nobody, everyone was like, what are you talking about? These diseases aren't preventable. I mean, the work that I was doing was dismissed as fluff. And I was told by a colleague that all I do is tell people to eat blueberries. I was like, yeah, okay.
I don't know if you're talking about the study that I read on blueberries, but let me tell you, it was funded by the blueberry industry. Yes, so that makes it an epigenetic disease.
For sure. And, going back to ApoE4, we do know that ApoE4 carriers are more susceptible or more vulnerable to the harmful effects of some of these risk factors like diabetes, like dyslipidemia, like obesity. So it's like they're predisposed, and then put them in the wrong environment, and those genes really do all the bad things for them.
Okay, so I've been getting a lot of hate on Instagram lately because I have spoken highly about, especially people with the ApoE4 gene, that a lot of the data points towards having an LDL less than 70 is ideal for long-term brain health and staving off Alzheimer's disease. How do you feel about that statement?
This is such an interesting area, first and foremost, and I would love, again, to have a perfect answer for this. So LDL-C, ApoB, I'm sure you've talked about this distinction plenty of times. ApoB is probably better because it's telling us more about the atherogenic potential of LDL particles. But, neurologists and the people, or the Lancet Commission is pulling on a lot of neurology journals, and neurologists check LDL-C. So all of these studies, are based on what we've done in medical practice for years and years and years. So we just don't have as much data about ApoB. That's a long story, but important distinction, even though it's a better metric. What is the ideal target for somebody? In my opinion, again, it comes down to personalized care and precision medicine. Are we seeing that somebody has a lot of evidence of microvascular changes on their brain MRI? In that case, we probably should be pretty aggressive in how we lower ApoB, LDL, treat their insulin resistance, treat their blood pressure. Do they have changes or coronary calcium plaque building up? Like that all changes what our target should be. What is the ideal target? I think you're probably right. An ApoB less than 70 is probably right. But again, we don't really know what the ideal answer is there. And lower might be better, but again, we just don't know.
But that then brings into question statins, which I'm all for because we can see the correlation. If we're going to reduce LDL-C and ApoB with a statin, then that's going to be a positive thing.
For sure. And again, no one size fits all.
Yeah.
What should somebody be on? It really depends on their risk factors, their biology. In general, statins have shown that they lower risk for dementia. And we do know that elevated LDL-C is a modifiable risk factor for dementia. So we got to address it without a doubt. And how we do that, what medication we do that with, we're still studying it. I wish I can say there'll be really robust data that says statins are the best thing to use or Zetia is the best thing to use. I don't think we'll ever have those studies. And again, it's so individualized in my opinion.
Why do I get messages from people saying, hey, Louisa, my mum was told by her doctor that she needed to take a statin, but I heard that raises your risk of getting dementia. I'm like, here's a study that shows that it lowers the risk. I even put it out on Instagram and I'm getting so much hate for it.
I get a lot of hate for it too.
And I don't know how many times I have to tell people that serum cholesterol is not getting into the brain and crossing the blood-brain barrier. I will take it to my grave.
Yes.
And do you know how many people actually will write on an Instagram post saying, this girl needs help. We all know that we need high cholesterol for the brain.
I know.
I'm like, what does that mean?
I know. It's really a lot of misinformation, and there's so much fear around statin use. It is mind-blowing, really mind-blowing.
I mean, there's fear.
All medication use, really.
Isn't it around 5% or maybe lower of perimenopausal, menopausal women are actually on HRT?
Yeah.
So it's still we've still got fear. That's WHI, which we don't need to bring into this right now, but there's fear around this. And if you push it or advocate for it, you are supporting Big Pharma.
For me, I joke about this and said it before, but I'm an equal opportunist. I'm down for anything that's going to work. Yeah. Medications, supplements, lifestyle changes, anything. Yeah. You have to be. If you want to prevent the disease, you have to be open to all of those.
Especially if you're at risk.
And, without a doubt, we know that elevated LDL-C, elevated ApoB is a risk factor, and we know we have to treat it. There are the studies on statin use are, unfortunately, we don't have the perfect study for it. I use statins in my patients at the appropriate dose in the right person, and I don't believe that they're associated with an increased risk of dementia. Do some people have side effects from statins? Absolutely. There are side effects and risks with every single medication, and that's why we just have to be thoughtful on what we use in a given person.
Well, a good physician will be monitoring
Absolutely.
progress even over a 4-week period. How do you feel?
Absolutely.
Do we increase? Do we decrease? Do we eliminate completely?
Absolutely. And I think you're right that there's a lot of confusion about LDLC. Our brain needs LDLC. It's not crossing through the blood-brain barrier. It's really not. It's impacting risk of dementia because it's impacting blood flow to the brain by getting caught in our blood vessels that feed our brain and depriving our brain of oxygen and nutrients and blood and all those things that we need. So it has nothing to do, our brain is not using LDL cholesterol for its important neuronal processes. It's just not. And unfortunately, we don't have great ways to measure brain cholesterol. Without doing a spinal tap, there are some great surrogate markers that we can talk about to kind of get a sense of it. But LDLC is not one of them.
Yeah. So I sent my mum to get a carotid ultrasound and a CAC scan 5 days ago because I noticed that she had a high Lp(a). So what are you seeing with high Lp(a)s? Because that's a genetic risk factor for CVD and one that you can't bring down with medication.
Not yet, but soon.
Yeah.
So again, the studies here are mixed, and I gave a talk to an Lp(a) support group, and a lot of questions about whether Lp(a) increases risk for Alzheimer's disease and other forms of dementia, and the studies are really not clear on this. Some studies say it does. There are plenty of studies that say it doesn't. Sorry, let's repeat that. Some studies say that it does. There are plenty of studies that say that it doesn't. Some studies say that it's the combination of ApoE4 with Lp(a) that makes Lp(a) problematic. We don't really know, and that's the truth.
But the best course of action would be to aggressively monitor ApoB if you have a high Lp(a), because that just makes sense, right?
And there's some evidence that may suggest that aspirin may have a beneficial effect in these people, and there'll be new drugs on the market.
Because of vasodilator.
Mild
blood flow.
Mild blood thinning effect.
Yeah.
And again, there'll be more drugs in the future to address Lp(a), and I'm really looking forward to that because I truly believe what's good for the heart is good for the brain.
I am crazy about what I put on my skin. You guys know this. I have recently discovered the world's best, and I mean it, the world's best skincare products. I don't know if you've heard of them, but it's from Jones Road Beauty. I've been simplifying my skincare routine and my makeup routine. And Jones Road Beauty is the reason why, because their daily moisturizers keep my skin hydrated without clogging pores, and their face wash has become a staple. I use it in the morning, I use it at night. What I love most is their formulas. They are so clean and skin first. They're designed to enhance your natural skin health, not overload it with harsh chemicals. Scientifically, hydration and barrier protection are key to skin resilience, and Jones Road nails both. For a limited time, you can get a free cool gloss with your first purchase. Guys, you have to check this one out. Head to jonesroadbeauty.com and use code NEURO at checkout. That's jonesroadbeauty.com, code NEURO. Team, if you've dialed in sleep, nutrition, and workouts, do you ever think about your mental health? For me, protecting my brain also means addressing the hidden stuff like intrusive thoughts and negative thoughts. NOCD is the world's largest OCD treatment provider, and their licensed therapists specialize in ERP, the most effective form of therapy for OCD. It's 100% virtual, covered by insurance, and you even get support between sessions. If you've ever struggled with thoughts that don't feel like you, or fears that spiral and stick, NOCD gets it, and the right therapy can change everything. Research shows ERP can significantly rewire the brain's threat response circuits, helping break the cycle of intrusive thoughts. So if this sounds like you and you want to talk to somebody, book a free call. at learn.nocd.com/neuro. That is learn.nocd.com/neuro to get started.
So the brain is the most vascular rich organ in the entire body, comprising of, we've got capillaries, we've got arteries, we've got veins, and those little capillaries are 1 cell thick. They're tiny, but they do their work in supplying the brain with blood, which is nutrients and oxygen. Now, they are the first things to go during high blood pressure and hypertension, which is why hypertension is a risk factor.
Absolutely.
Are you aggressively monitoring that? Because the SPRINT trial really changed my life.
Yes, absolutely. So optimal blood pressure control is of the utmost importance, but we talk a lot about high blood pressure, so I just want to mention low blood pressure.
Talk to me, because I'm low. I don't know whether it's, I don't know if I'm fit enough to have this much of a low blood pressure.
You know, there's a lot of people who are like, there's no such thing as having too low blood pressure. Well, actually, we do know that at least in older adults over the age of 65, having too low of a blood pressure is actually a risk for dementia. So we have to just be really careful about personalizing our blood pressure targets for the right person at the right time in their life. We don't want to be dropping someone who's 70 years old blood pressure down because they may have evidence of small vessel disease where that perfusion pressure is really needed to allow adequate blood flow to the brain. So, you know, what is the ideal blood pressure for most healthy young to middle-aged adults? It's probably less than 120/80. I also have relatively low blood pressure.
What is relatively low?
90s/70s.
Oh, okay. I'm better than that.
There you go.
Sometimes I'm like 102, 103.
Yeah. So, you know, that's my whole life. And that's probably been a whole life thing for you. And women tend to, you know, have lower blood pressure in early and midlife. I don't think that that's a risk per se.
You're talking much lower.
I'm talking about aggressively reducing people's blood pressure where they hypoperfuse.
Yeah. My father in 2019 had a stroke. It was a right parietal lobe infarct. And, you know, my mum measures his blood pressure every day. So I was just home in Australia. I was like, can you show me how you're doing it? God love him. It's the automatic one, and just whack it on. However, my dad's like walking around. He's crossing his legs. He's like, you know, I said, we have to have a masterclass, because I think that's another, like, this is a very sensitive. Oh, yeah. Yeah. And I'm used to doing it the old-fashioned way, manually. Yeah.
You know, you have to be sitting down. Yeah. You have to have no exercise right before. Relax, like wake up, sit down, sit quietly for 2, 3, 5 minutes. Put it on your left hand, roll up your sleeve, rest your arm at about breast level, and make sure it's matched up to the middle of your arm. So there's a little, there should be a little marking where you're matching it up. And you want to do it very consistently. Legs uncrossed, back against the back of the chair, go to the bathroom beforehand. Yeah. Like, don't, you know, my dad does this too. He like goes and he's out there and he's mowing the lawn, and then he comes back. He's like, my blood pressure is 145. I'm like, well, you just, you know, like we're all flustered outside in the backyard. Like, you got to chill out a little bit before you check it. So it's a really common thing.
I'm mad right now, and I don't know if you share this. And it comes down to the medicalization of this disease. We have FDA-approved IV therapies for Alzheimer's disease patients. The New England Journal of Medicine showed the results of, was it lecanemab? Yep. Showing that it causes microhemorrhages and brain bleeds and some brain tissue atrophy and some death in some patients when taking the IV. That upsets me. And it's also an expensive IV that I think needs to be administered how many times a year if you were to get it?
It depends on what protocol you're using, monthly, twice a month.
The reason I bring this up is because I want to have a detailed conversation about what's happening right now in medicine and this disease. And we can go into ICD-10 codes and why preventative neurology is not really recognized as a specialty.
I'll just put one thought out there about anti-amyloid drugs, because I think there's a lot of fears about them. And people who, you know, understandably feel like they don't do a whole lot for the disease. I think the truth is that we haven't studied them in the best way possible, meaning the timing of administration and the right person to administer them in. Is this going to be a holy grail? No, like I said, we're going to need multiple drugs with multiple different targets to really, really get at this disease. But it is progress, and it is an option for people who are affected by these diseases. And I hope that it'll be an option for people who are in the much, much earlier stages of disease if we can identify them early enough. But that goes into your second question, which is like, what's going on with preventive neurology? Like, why doesn't this exist? Why can't I see a neurologist at a hospital that's going to take any of these complaints seriously? And
complaints such as what? Loss of memory?
No, complaints such as I'm worried that I might get Alzheimer's disease.
Yeah.
Like, that's a legitimate complaint. I have risk factors and I want a doctor to think about me and my risk profile.
But how many people are actually doing that?
How many people are practicing?
No,
this?
how many people? How many people are patients are actually going to the doctors, to going to their, whether it's their primary or a neurologist, saying I'm concerned?
A lot. I get messages from doctors asking me, like, we're getting waves of patients who are interested in this. When I was at Weill Cornell managing the Alzheimer's prevention clinic there, our waiting list was 5 years long. I have a waiting list now. I mean,
not for at risk, just people concerned.
Yeah, for people who are concerned,
Wow.
which is at risk.
Yeah. Okay.
At risk people with family histories, known genetic risk factors. But there's no perfect place for them to go in our current medical setting. And I am so passionate about talking about this because it really has to change. And I really hope that I can be a part of that movement leading to change. It is going to require so much of so many different people. First and foremost, we don't have formal training programs where neurologists can learn and even primary care doctors can learn how to take care of their patients, keeping their brain in mind. We don't have fellowship programs for preventive neurology. My mission and why I was brought back to Weill Cornell was really to help establish a formal training program. We established it with me, and then it went, and hit the floor, and that was it. I was the only fellow. So we need training programs. That's the first step. So doctors feel comfortable providing this level of care. But alongside that, we also need appropriate billing codes for preventive neurology. Right now, there's no way for your insurance to cover family history of Alzheimer's disease or ApoE4. That's not a diagnosis that reimburses hospitals and medical practices in any meaningful way. So until we have payers buying in and believing in the power of prevention, it's going to be a long time before this field is fully formed. But by talking about it, by building training programs, we're allowing for more research dedicated specifically to this area to provide the evidence to hopefully take to these payers to show them, like, look, this stuff works. There's lots that we can be doing for our patients. Please start covering this type of care.
Yeah, and it's sad and it's scary because it's an expensive disease that not a lot of people can really afford.
It's beyond expensive. And, as a physician, what's so frustrating to me is that whether you're on Blue Cross Blue Shield today or Aetna today or whatever it is, at some point, someone is going to be paying for that cost of that patient that has Alzheimer's disease. And if we all collectively agreed to pay into prevention early on, then we would all benefit later on. And it wouldn't be like, I don't want to pay for this because this person's going to, in 30 years, not going to be on my plan. They'll be on someone else's plan. They'll be someone else's problem. But it's not someone else's problem. Like, this is our collective problem in America that we have to address together.
Why do you think America isn't giving preventative neurology an opportunity and these at-risk patients?
I think it's just been slow. Like I said, I'm grateful for the Lancet Commission that really was one of these prime publications that show that a large majority or a large portion of dementia cases are preventable. Their first publication only came out in 2017. And to put this into perspective, preventive cardiology, the early studies were in the 1950s and 1960s, and it wasn't until the late 1980s, 1990s that the field of preventive cardiology really started to grow. It took 30 years, It's going to take a long time. And fortunately now with social media and the internet, I think we can get messages out there quicker. And I'm hopeful that it won't take that long, but the American Academy of Neurology says that they hope it exists and is a budding, flourishing field by 2050.
Oh, wonderful.
And that's
right when there's going to be 150 million people with the disease.
That's, yeah, I know. And 25 years from now, we can start today.
Why do you think Alzheimer's disease rates are going up and why it's going to triple by the year 2050?
Yeah, it's a great question. I mean, right now we know we have an aging population. The baby boomers in particular are aging. And we know that 300, like you mentioned, 50 million people. There are 300 million people living with early evidence of Alzheimer's disease, meaning they have the pathological proteins in their blood, in their brain, but are walking around unknown.
Well, they could be asymptomatic.
Exactly. That's what they're 100% unknowingly. We're about to hit a really big epidemic of neurodegenerative diseases, and we can pontificate on all of the different reasons for why that might be true. Is it because there's increased environmental toxic exposures and pollution? Sure, that could be it. Like I said, the aging population, a long-standing American diet, which was pretty poor, lack of physical activity and a sedentary life, which is true for a lot of Americans.
And we're also getting more stressed.
Yes.
And that's a huge risk factor. What's your take on people calling Alzheimer's type 3 diabetes?
I'm a little hesitant to say that, but it is true that at least in some instances of Alzheimer's disease that there are metabolic changes that happen in the brain. The utilization of glucose changes in the brain. I mean, it's one of the ways we can diagnose the disease by using PET scans that show us metabolism of glucose in different brain regions. So without a doubt, there is evidence to support changes in glucose utilization, energy utilization in the brain. Whether or not that's type 3 diabetes, I don't know if I would necessarily
so much more nuanced than that.
Label it as that, but yes.
Alzheimer's disease is such a long progression, and I think to actually be diagnosed, you're really at end stage there, because before that, where you've got, I don't even know how you classify the stages, but you've got subjective cognitive impairment, mild cognitive impairment, which is a pre-dementia state, and then it's early onset. Right. It's not exactly if you come with these symptoms and you've got some pathology, you don't have the disease, most likely. That progression takes around 20 or 30 years, right?
Yep.
What are some of the changes somebody would experience along that process?
Yeah. And the earliest changes can be really subtle and difficult to clearly point to a brain issue. So things like loss of sense of smell, for example, that can happen 30 years before the onset of Alzheimer's, Parkinson's, Lewy body.
That could be anything.
But that can be anything.
Yeah.
It could, be related to chronic sinus issues or head trauma or COVID. There's so many things that can cause our sense of smell to be affected. So, it's hard to point to. Mood changes in sleep. Insomnia, for example, is a big one. Those, again, are really hard for people to point to. Is this a problem related to my brain, or is this just hormones?
That's like forgetting somebody's name or something. You get a brain. Often when I'm on a podcast, I'm like, oh, I want to say something. What was I going to say?
Yeah.
It's doesn't mean I've got early onset. It could mean stress or lack of focus.
Yeah. And then, some subtle cognitive changes can happen to people. And those subtle cognitive changes can be difficult for even neurologists to really differentiate between. Like you mentioned, that word being at the tip of your tongue, that's really common as we get older. It's a part of normal cognitive aging, but word finding difficulty is also a problem in Alzheimer's disease.
Language processing.
Yes, language processing, losing track of where they were in a conversation. Like those are issues that also happen in Alzheimer's disease, but they can also happen to people who aren't paying attention. So it can be really, really difficult to know the difference and to really differentiate the difference between these subtle or subjective cognitive complaints and normal cognitive aging versus just a busy lifestyle, inattention, information overload.
We touched on earlier amyloid, right? But we forgot to even talk about tau.
Yes.
Because tau it lives in the microtubule space of the axon, which is within the neuron itself. How is tau activated and built up? And what is it?
So tau is another neurotoxic protein, and feel free to jump in on any of your expertise here, but it's another neurotoxic protein that forms tangles in the brain. It becomes phosphorylated, which is a really fancy way of saying, it is more predisposed to clump together into tangles.
And go crazy.
And again, just like amyloid, trigger an inflammatory process, which, as you alluded to with amyloid, does the same things, interferes with synapses, can become cytotoxic, can lead to cell death once these proteins are stuck inside the cells.
Well, it's the collapse there of the axon itself, which as a neurophysiologist, I've done a lot of EMGs, and we're usually measuring something called conduction velocity, mainly in MS patients.
Right.
And that's what I tell people, like conduction velocity of, the way that we think and move, and that's where it ends up collapsing.
Yes, exactly.
To trigger amyloid, it's triggered via the innate immune system, correct?
That's a really loaded question. What causes amyloid? I don't know. We don't know. The immune system's involved.
The innate immune system is, okay, let's just pencil that there. The innate immune system is involved. We can't just clear it via the glymphatic system. There's got to be more to it than that. Because that means it'll just put you to sleep. Okay.
Wash your brain.
You wash your brain. And I know it's so easy to say, during sleep, during N3 stage deep sleep, we go through this washing process. It's so much more nuanced than that. So let's just say someone's building up this amyloid from God knows what. Now that you've just informed me and broken my heart, what clears it?
Our microglia, our supporting brain cells help clear amyloid plaques from the brain.
Is that the only way?
I mean, as you said, the glymphatic system does clear it. What else?
Then sleep is really important.
Sleep is really
because it's
important.
only really it's activated as well elsewhere, the glymphatic system, not just during sleep.
There was this super interesting study that came out recently from a group in Korea. It was done in mice, so take it with a grain of salt. But, they recently discovered that glymphatic clearance also happens through the skin, and that there are certain glymphatic massages that can help clear toxic proteins and improve cognitive function in mice. And they actually really demonstrated this beautiful, what I thought was amazing about the study was that they actually demonstrated this beautiful pathway of lymph clearance from the face going out. Like you could see it on the video. It was really amazing. And I met with the researchers because they want to develop some facial stimulation device to help with this. But it's so simple. You can just do a simple face massage on these key areas where our lymph nodes are on our face to kind of like help support lymphatic clearance. And will that ever end up helping someone's cognition? They said that you have to do it 3 times a day for 10 minutes. It's, 30 minutes a day. Add that on to your exercise, your good eating, your good sleep, your sauna, whatever else you're doing for your brain. It's a commitment.
Oh, yeah.
But I do think the interesting thing about that is, we're still learning.
Yeah.
We still have so much to learn about this disease. And when we talk about like the glymphatic system, we had no idea that the glymphatic system was attached to our skin and there was a clearance mechanism that way.
How about tau? Can you eliminate tau?
The thought is yes, the same pathways.
As a neurophysiologist, I've had those moments where I second-guessed what I heard through a stethoscope. Was the subtle murmur real? Was I missing something in a noisy environment? That's uncertainty, and it's extremely stressful. I'm so excited about this new device, Echo's digital stethoscope. Honestly, it amplifies sounds up to 40x. It cancels background noise and even uses AI to detect murmurs or atrial fibrillation. My father has AFib. I would have loved to have used this on him 20 years ago. It feels like having a cardiology consult right in my pocket, helping me be more confident in assessments and give patients the best care possible. If you want to hear with precision, if you are in the medical field and you don't want to use the Littmann boring stethoscope anymore, you need the EcoHealth stethoscope. Just go to ecohealth.com/neuro to get $50 off plus a free customizable chest piece cover. That's ecohealth.com/neuro.
One of the biggest controversies I face in this area is diet. We've got the MIND diet, and we've got this bandwagon of two players, both two neurologists. Neurologist A is saying the neuron works better when it's fueled by ketones. So being on a ketogenic diet is much better for healthy neurons and the brain. Then we've got neurologist B who is saying, no, the MIND diet clearly showed that a diet rich in plants and vegetables is the best for your brain. And so it's so ideological because you've got, neurologist B really going hard on only having plants and demonizing red meat. Then you've got neurologist A saying, no, get you into a ketogenic state. I'm Switzerland.
I'm Switzerland too. There's no one size fits all. I've seen people go on the ketogenic diet and have caused pretty significant problems with inflammatory profiles, cholesterol panels. I've seen the opposite also happen, that they say they feel cognitively clearer, they feel like they're processing much quicker, their attention is better, their learning is better. Again, there's no one size fits all for nutrition and diet. I think the ketogenic diet is extremely difficult to live by. It's extremely restrictive. And I'm all in the business of making this as accessible and as easy for people as possible. So my preference is always to support a more Mediterranean mind-based diet because I think it's just really sustainable for most people. And, it's even hard to get people to commit to one thing, like eating more fatty fish. Like that can be a lift for people.
I think the plant-based neurologists believe in vascular health because that's what it would come down to, right? If you want to maintain a healthy brain, you want to maintain good arterial health. And in order to do that, you have to really aggressively lower ApoB and LDL-C. Therefore, don't have any food with saturated fats in it. That's my understanding of why people push this narrative so much.
Well, the Mediterranean mind-based diet also has things like fatty fish, extra virgin olive oil, all things that have other brain benefits that you may, those two things you won't miss out on, but the antioxidants that are rich in berries, like you'd miss out on that on the ketogenic diet. And there's just so much nuance when it comes to choosing the right diet for the right person, but I'm definitely not on the side of making someone's life really difficult. I want this to be as easy as possible and as sustainable as possible because when we're talking about prevention, this is something that you're going to have to do for a long time, if not the rest of your life. No one's going to be perfect on their diet. And you can't be, and you shouldn't be because you should live your life.
Yes, you got to be happy. Happiness is actually a big predictor.
Happiness is huge.
So then what are you prescribing? Blueberries every day? Because I know that blueberries are great for the brain. Antioxidants.
So, have I used a ketogenic diet in the right person? I have experimented with that, but in general, for most people, I do recommend a Mediterranean mind-based diet. So 2 to 3 servings of a fatty fish a week. If you don't like fatty fish, supplementation might be necessary for you. Lots of berries, lots of leafy greens, limited refined carbohydrates like pastas, and sugary things like corn syrup. Try to eliminate processed foods. Dairy is okay. People are always like, should I be eating dairy? That's such a complicated topic. But trying to avoid, as much as you said, forms of saturated fat, but also recognizing that you're a human that has to live your life, and this shouldn't be a thing that you feel resentment towards. It should be something that you feel happy and excited to do.
In your practice, let's just say you identify a patient who is either at risk, let's just say at risk, moderately high, or whatever it might be. Do you take them through a set of cognitive tests?
I think there's a lot of benefit in doing baseline cognitive screenings on people, especially with vetted tools that we have clear established norms on.
Are you using an EEG?
I don't use EEGs, but I've explored that and have looked into various EEGs. I think EEGs, there's a lot of noise in EEGs, and I'll remind myself of my time reading EEGs in training, and it's like watching paint dry. I think that for the purposes that I recommend, I would suggest doing some sort of cognitive screening to get a baseline. And the reason is what I mentioned before. Subtle changes to your cognition are really difficult to detect, especially in people who are extremely high functioning, who are working professionals, who have multiple degrees, for example. They can mask cognitive changes very, very easily, and they may present to a doctor and say, hey, I'm having word finding difficulty, and they're going to ace the test or ace the test. Score normal, and the doctor's going to be like, you're completely fine, like you're scored completely normal. But it doesn't mean there wasn't a change from where they were at age 35, for example. So I think there's a lot of value in establishing a baseline that can be followed longitudinally and can serve as an important metric to look back towards.
But you can also do cranial nerve testing as well. We mentioned offline, we were talking about olfactory nerve. And we're talking about maybe blindfolding patients. I don't know if you would do this and making them smell different things and seeing if they can pick up on the smell, like cinnamon.
We do a sniff test with people.
A sniff test, yes.
We don't blindfold them. It's already like a perfect vetted test that someone has created, thankfully.
Yeah.
It's a scratch and sniff test. And I find that really, really informative. It's not informative as a standalone test, right? But in the picture of everything that you collect on someone, it does help inform risk.
And correct me if I'm wrong, one of the latest introductions into the risk factors was hearing loss.
Lots of debates on why this could be, and it, again, probably is multifactorial. One thought is the brain is very use it or lose it. It needs lots of inputs, lots of sensory inputs to maintain neuroplasticity. And where hearing is processed is our temporal lobes. That happens to be the area impacted by Alzheimer's disease. So hearing is really that sensory input. That part of the brain needs to stay healthy, happy, active. But also, if you lose your sense of hearing, you're more likely to be socially isolated, which is another risk factor for Alzheimer's disease. You're more likely to have mood derangements.
I thought it was because of the temporal lobes.
Exactly, like that, the
area.
The stimulation, for sure, but vision loss was recently added to this list.
Okay, so that's the latest one.
That's the latest one, and I believed that was a risk factor for a long time before it was added. Vision is so important. But that feeds back into a different region of the brain, our parietal, our occipital lobes. And again, there's that idea of it's use it or lose it. But again, if you are not able to see, you are also less socially engaged. And I think all of these risk factors do go hand in hand, and there are downstream or indirect consequences of all of them, and they're related.
Do you think that we don't pay enough attention to the cerebellum?
Oh, Yes.
I know, me too.
The cerebellum is so cool.
I know. I mean, do a, one-legged, just stand there on one leg, see how long you can go for a minute. Why do you think we're not paying attention to the cerebellum?
Because, we view the cerebellum as the separate part, as like the basement of the brain, like its own little brain. And the cerebellum is extremely complicated. I remember, studying all the cerebellar pathways in neuroanatomy and becoming very easily overwhelmed. We don't even fully understand all that the cerebellum does, but it's involved with motor planning and motor learning. It's involved in our accuracy, our balance, our coordination, posture. It's where when people drink alcohol, the alcohol is hitting. It's directly toxic to our cerebellum. I really think it's important, and I know we're not really focused on this for this discussion, but I think it's really important in Parkinson's disease because that tremor is your brain cerebellum not being able to find a target. We do see kinetic tremors in Parkinson's disease a lot, and I think more and more attention will be given to the cerebellum, but it's one of my favorite parts of the brain.
I know, right? Me too. I got that in common as well. Before we move on to prevention as a whole for everybody, I'd be remiss if we didn't bring up exercise, which is where I publish most of my data, looking at really the effects on exercise as a whole, but mainly resistance training on mild cognitive impairment. What's going on there?
Yeah, well, maybe you tell me because you're the expert here, but I think exercise is probably the biggest lever that we can all pull for protecting our brains and for our health collectively. Like, the most important thing, in my opinion, for people who are sedentary is just to get up and start moving. Even like getting up and walking can be incredibly powerful for these people. But of course, there are better ways to optimize exercise. I really do think a combination of resistance and aerobic training is necessary. I think they give different benefits to the brain. But the truth is the optimal dose, duration, intensity isn't fully understood.
Well, I did a meta-analysis and really found, after reading like 2,000 papers and going blind from doing it, that it comes down to around 2 days a week.
Okay.
Which you don't need a lot of exercise to increase longevity benefits. Like people, I think like Instagram's just taking this out of proportion. You don't need that much, right? Yes, you do if you want to look better and feel better. Yes, but that's a different story. But when it comes to the mechanism of action, what I really nail it down to is A, increased blood flow. B, we've got, if we grow muscles, and we've got more mitochondria, right, which we haven't touched on. But then you've got the myokine pathway.
Yes.
And the myokines are, even if we're thinking about like IL-6, irisin, obviously BDNF, which are fantastic for the brain. I think that's the major pathway that I see working, because some of them cross the blood-brain barrier, some of them are anti-inflammatory. Yeah,
absolutely. I think you nailed it. And I think different forms of exercise have different benefits for the brain. And, the thing about resistance training and how we're talking about the interrelatedness of all of these risk factors, like a huge risk for Alzheimer's disease is falls, head injury. If you have really low muscle mass, your risk of falls is so much higher. So whether they're direct benefits like all the ones that you just said, or indirect benefits in terms of reducing someone's fall risk, like exercise is really, really important.
All right, let's talk more about prevention.
Okay.
Give me everything. What does average person, because not everyone's going to get to see you. Not everyone is at the stage of understanding if they're at risk or not. What is if you were to tell the world, here are my top 10 things to prevent Alzheimer's disease, what are they?
I love this. Okay, put me on the spot. Well, first, in my opinion, is really understanding what your individual risk is. And that may be understanding your family history. That may be understanding your genetics, if that's right for you. But that really is a window into your risk and what areas you should really focus on. And I, again, am in the business of personalized and precision medicine. So that's kind of where you turn first. As you mentioned, we'll say exercise is important. It doesn't have to be super intense. You just have to be consistent with your exercise, and a combination of cardio and resistance training is what I point to. A Mediterranean mind-based diet, in general, we're giving generalities here. So in general, that's probably right for most people. Getting your hearing and vision checked, super important. Easy, low-hanging fruit. We just talked about how important these things are for the brain. Getting your cardiovascular risk factors in check, making sure you screen your cholesterol and not really accepting when your physician might say that your cholesterol is, quote, normal, even if you're, 25 or 35, like high cholesterol is high cholesterol. It's only a matter of time before that will cause issues for you. So addressing that sooner rather than later is important. Making sure your blood pressure is well controlled, checking it on your own. Doing a log on your own is probably best because when you're in your doctor's office, you're flustered. You might be a little worried about seeing the physician. Checking it on your own in your own environment when you're most comfortable is going to give you the most accurate readings. Getting your metabolic health under control, whether that's through diet, through exercise, but also just checking your metabolic numbers to make sure that you are as honed in as you actually think you are. Super important. And then getting the right amount of sleep for you, making sure your sleep is quality, you're getting enough, you're making enough time for your sleep. And if you aren't sleeping, you're getting to the bottom of it. Is it stress, rumination, anxiety, pain, waking up to urinate? Like what's leading to your lack of sleep? Get to the bottom of why you can't sleep.
I don't think that everyone needs to be supplementing, full stop. What are my favorite supplements across the board for everyone, though? If I had to choose two, which I do, it's omega-3 fatty acids and creatine.
Okay.
And then upon blood biomarker checking and blood work, if you are deficient in other nutrients, like if you're deficient in vitamin D, then great, supplement with vitamin D.
Yes.
So these are my two. Where's your stance on that?
I'll even go as far to say that I 1,000% agree. Everyone does not need to be supplementing. Some people don't even need omega-3 supplements because they eat enough fish. They grew their own gills. So great, good for you if you're that person. You wouldn't know and checked until you checked your own levels. But I find that most people are deficient in omegas, and it's difficult to eat enough fatty fish to get your levels appropriate. As you said, if you're deficient in certain B vitamins or D vitamins, then it's really important to get those corrected. But there's no prime supplement lists that I recommend people because I don't think supplementation is like the answer and what's needed for most people.
Yeah.
Of course, there are situations when you do need supplements, and we'll always address that. Creatine, I think, is very fascinating. It's getting a lot of attention now. You probably have stronger feelings about it than I do. It, in the short term, does help enhance cognition. There have been studies that showed really high doses of creatine may help improve cognition in people with mild cognitive impairment. I've had people go on creatine and feel really bloated, a ton of gas. So like, again, I don't recommend all supplements to everyone because it's not right for everyone. But there are more supplements to that list that we can talk about that may have some sort of immediate cognitive enhancement. But
B vitamins, alpha GPC, choline.
What other ones might have immediate cognitive benefits?
Please don't say lion's mane.
Oh, no, I wasn't going to say lion's mane. Certain magnesium supplements, some people feel like they give them a cognitive boost. The rage right now and what has made its rounds most recently is lithium, or low doses of lithium. And I've had patients report cognitive improvements when they started very low dose lithium, like subjective, maybe. I don't know. Like
that's still, placebo effect is still real.
It's still real for sure. Caffeine is,
of course,
like an enhancer, and you can get caffeine from lots of different things. Cocoa powder, there are other things that can boost cognition, but there's no one size fits all.
People ask me, why are you dedicating your career to this disease? I haven't personally been affected in terms of family history. As I mentioned, it's more so cancer.
The Greeks.
Yeah.
I have
we're
a
both
lot
Greek.
of cancer.
Yeah.
My family do.
And so you'd wonder why it's not that. I think I obviously fascinated by the brain. That's what I chose to study for my career. But a woman changed my trajectory. In 2018, I was responsible for doing EEGs and really picking up on early onset Alzheimer's disease. And I can't tell you how many scans I have done. And the one woman came in and only in her early 50s and 3 kids, husband, and her husband's like, she's forgetting who we are. This is getting serious. I was younger than what I am now, and I kept asking the attending, who was my boss, saying, he's like, Louisa, just get him in, scan, give him the results, get rid of him. And it really hurt me because when I went through her history, she's like, I did everything that my doctor told me. I exercise and I eat well and, I'm working and they're not really rich, I couldn't help her. Because I didn't have the tools, the knowledge, and it wasn't my place to help her. And she plays on my mind every day. But she took a real steep downhill battle, and I saw the progression even over a year of the progression was steep, steep. And it gets to a point where there is so many people outside waiting for me, and all I could tell you was seek help elsewhere. But that wasn't my doing. It was obviously where I was involved with, and I haven't stopped thinking about that. Now that I know that back then I used to ask all my attendings, can't we prevent this? No.
I mean, that story also speaks so closely to me and my experience. I do have a family member that has been impacted by a really atypical form of dementia, where she was accompanied by a lot of neuropsychiatric issues as well. And we actually have never gotten a formal, full diagnosis for it. But to see her lose herself, lose her personality, lose her connections to her family, who she was once so close with, is completely devastating. And that situation that you described played out for me countless times while I was a trainee, seeing Parkinson's patients who asked, what else can I be doing?
Yeah, that's
what else can
me.
I be doing? And for us to say, eat better and exercise more didn't feel like enough. And I was fortunate enough to cross paths with such an amazing mentor, Richard Isaacson, and he showed me a different way to thinking about neurodegenerative diseases. And it was so evident to me that the patients that were following recommendations that we spoke about today on this podcast did much better than the ones I was seeing outside of that setting. And I truly, truly, truly believe that not only is dementia preventable, Alzheimer's disease preventable, but also that people who are impacted early on can still do things to change the trajectory of their disease. And that, all hope is not lost. The disease looks so different in different people. And I do believe that what you do personally impacts how this disease looks.
I'm very passionate about women as well because she was a woman, and my grandmother, who was my best friend, was told I remember her asking her doctor, because I went to all her visits with her, she said, what else can I do, to the doctor in Greek? What else can I do? I don't want to die. And the doctor said, nothing. You can't do anything. And so this is why it touches my heart, this disease, because 2 out of 3 patients of Alzheimer's disease is female. And I'm so strong and bullish on hormone replacement therapy because I've seen both clinically and in the data what it can do. It can change your life and the trajectory of your life. It can change your children's life and your spouse's life. And people don't understand that this is the only disease that robs you of who you are, and every single memory that you have. Every memory that you are building in your 20s and 30s and 40s can be taken away from you just like that because of the choices that you choose to make in your 40s and in your 30s. And I'm so passionate about preventative neurology. I love what you're doing.
Thank you.
Thank you for coming on the podcast.
Thank you for having me. This was such an awesome discussion. And, thank you for getting the message out there that preventive neurology exists and it's going to grow.
Yes.
And in our lifetime, we're going to see it be a huge, huge, huge part of medical care. And the more people that care about it today and the more this message gets out there, the more power we have to really disseminate this message. So thank you for this opportunity.